Hello, the lovely Cam followers. It is a pleasure to see you tonight. We have the lovely Drew Tootal from Nupsala Musculoskeletal Clinic, who's going to be joining us tonight to talk about the future of OA management. So I'm very excited. Two things to just talk to you about first. We now have a wonderful thing in place called Facebook Stars, where you can say thank you for all the hard work that we put into these Facebook Lives by purchasing some stars and donating them to Cam. For every star that we get sent, we get 1 cent, 1 cent, 1 American cent. So we would be really grateful if you purchase stars and you throw them our way. Now, to encourage you to do that, we will pick people's questions that have stars attached to them as a priority. So if you've got a really pressing question, throw some stars on there. We'll scroll down and we'll try and get to your question first. Second little bit of housekeeping before we begin. I just want to remind you all that we have an amazing book. It was written in Moscow airport when I accidentally got my visa wrong and I got stuck in an airport for 24 hours. But it is a children's illustrated booklet, really trying to help people understand the signs of pain so that we can prevent these horrendous episodes where maybe somebody in the family bumps into a dog that's slightly painful, moderately painful. The dog turns around and goes, "No, that hurts." That's misinterpreted as the dog having a significant behavior change and being relinquished, or even worse, put to sleep. So that book is a must as far as I'm concerned. I want it in every primary school, every library. I want it in the brownies, the cubs. I want it in rainbows. I want everybody to have that book. I would like every drug company to give that book away for every non-steroidal purchase because I think it's hugely important. There you go. I'm going to get off my soapbox. I apologise. I've got a COVID tonight, so I might be a bit antsy, but Drew's prepped. It's all going to be fine. Drew, introduce yourself. Tell everybody about what you do, and then we'll crack on the topic tonight.
Okay, well, thank you for having me, first of all. And I really hope the COVID doesn't come down this line. I've been there. I bought that T-shirt. No thanks. So my background is I qualified in 2004, and I went straight into the army with the aspiration of only joining up for 4 years. And after 17 and a half years, I finally left. And most of my time I was lucky enough to be just doing dogs. It was looking after dogs and buying them and helping train them and all these things. And so in April of last year, I finally left the military and joined the Nupsala MSK Clinic. And what we do is basically using objective gait analysis to try and detect osteoarthritis early, but also to use it as a monitor for progress in response to therapy. So that's me.
So first of all, we're going to talk a little bit about the changing face of OA, because one of the things that we really need to tackle before we start talking about all of these amazing interventions and objective monitoring and diagnostics that we now have is sadly changing public opinion about OA. There's still a real big perception it's an inevitable. There's a perception that it just comes with aging and there's nothing you can do about it. Got to suck it up, princess. Humans get it too. We have to learn to live with it. And there's a real kind of apathy about picking up the signs of it early and trying to proactively change the course of that disease. The truth is so far from that. In dogs, we know that it is mostly associated with developmental joint disease. So that means that occurs when the dog is young. So we have these bubbling cauldrons of OA starting at a very young age, and then we only pick up on them when they're late. So 50% of OA cases are not actually diagnosed until they're between 8 and 13 years old. But those dogs are likely to have been presenting signs earlier in their life. So what we've got to do is start changing the way our attitude towards this disease. And I'm just going to throw some figures that came from Duncan Lascelles' team, which is going to hopefully springboard into Drew's work of identifying the disease earlier. So they did a study And there was 123 dogs between 8 months and 4 years old. And they were taken in and they were clinically examined by a blinded veterinarian. He didn't know what was going on. He was just doing his job. And that dog was then also radiographed. Every peripheral joint, orthogonal views, so 90-degree angle, orthogonal views of each joint was taken. And then they brought all the data together. And 40% of dogs, of the 123 dogs, actually had radiographic signs of arthritis in at least one joint. So these were dogs that weren't picked because they were showing signs of pain. They were randomly picked. Nothing wrong with them. 40% of them already had radiographic signs of osteoarthritis before the age of 4 years old. And 24% of that 123 had clinical signs associated with the radiographic signs. So a joint that had radiographic indications of OA, when manipulated by the clinician, had signs of discomfort. So that's pretty damn scary to think that we have such a high prevalence in such young dogs. What's even more interesting and quite sad is that 57% of the dogs that had clinical signs of osteoarthritis, the owners knew something was wrong. They picked up that there was something not quite yet, and quite right. But only 13% of them were actually receiving any form of treatment. So there was 57% of people going, something's not quite right, but only 13% of them actually took it to the next step and got appropriate care. So those figures are really showing that we've got quite a big problem on our hands, and that this is not a disease of the older dog that we pick up when they're really, really lame, and there's not much we can do but put them on an anti-inflammatory and further analgesics, etc. So hopefully that springboards nicely into the sort of work that Drew's doing. So Drew, now kind of tell us what you're up to so people can see the relevance of it.
Okay, so I think what underpins everything that we do is we're very lucky to have an instrumented treadmill, and it basically looks for all the world like a standard running treadmill. It's about 8 foot long, and it can run on the flat, it can run on a slight incline, decline. And the beauty of it is that once we get the dogs on it, with only 30 seconds of recording time, we can get a wealth of data about how that dog is moving. Now, that's really, really important, because what we've shown when we started this, when we opened up this clinic in May last year, the clinical applications or the clinical facing of objective gait analysis is really something. It was more in the academic sphere. Trying to apply that to clinical problems and clinical presentations has just led us to run every size, shape, breed of dog, and everything from clinically completely normal to really, really severe advanced disease. And what we're trying to do is to build up almost like a database of information about what dogs are affected, how they move, what makes them do the things they do. And there's some really interesting data that's been coming out of that. So, for instance, there's a case that one of the early cases that we saw that springs to mind, and that dog actually had really quite severe elbow arthritis, and we knew that. And it had surgery. It had surgery when he was only 18 months old, and the vet who referred him to us also reported back pain, reported hip pain, etc., etc. Now we took that dog, we ran it, and when I say run, we will take the speed that we can get safely, that the dog is comfortable with. But we took some baseline data on that dog, and then we treated it, and we treated both his elbows with intra-articular therapy. And the really interesting thing that happened was that not only was he more comfortable on the areas that we treated, but actually he had been so long affected by this chronic pain that he had developed compensatory gaits. Mm-hmm. And so as a result, because he was trying to offload from his front end, it was putting a lot of stress through his lower back, it was putting a lot of stress through his hips. And we could actually physically see this on the treadmill. When we ran him at just 1 month after injection, nothing else happened. He was already on excellent analgesia plan. He wasn't overweight. All his lifestyle changes are in place. And when he ran the first time, his head was up here.
Yeah.
When he ran the second time, his head was down here. And what that did was then just relax all of his back, relax his hips. And so this is a sort of thing that we're trying to sort of figure out now is, where is the pain? What we sort of using the mantra, chase the pain. Let's really localize what is bothering that dog right now. What's the most important thing that we need to address? And then we sort of prioritize from the really, really badly affected that's causing a lot of pain, and then sort of work our way across the body.
Definitely. I think that's probably one of the things that drives me quite mad about being obsessed with arthritis, is that people almost want you to try and treat it in a one-hit wonder. And I'm always saying to people, it's like peeling an onion. We're doing the first layer, and we'll do the second layer. And it drives me mad that people that have a dog that's, say, diabetic, they totally accept coming in for repeated blood tests, repeated interventions, repeated monitoring. And it's almost like they accept that there's going to be regular revisits, heart disease, as I say, kidney disease, all these things. For some reason, it doesn't have that same attitude in OA management where, right, so we'll see you again in 3 months and we'll see what's changed, and we'll chip here, we'll chip away there.
Mm.
There is this terrible belief that it's going to be a one-hit wonder and then that's it, isn't? Do you find the same?
Absolutely. And I think from broad experience, I think that's true. I think that the people that have been coming to us at the clinic have already bought into the idea that arthritis is a journey.
Yeah.
It's definitely not. It's not a, we're on the train, we're going to take a tablet, or we're going to use a new medication, and then we've reached our destination. It is a journey. There's stops along the way. There will be pitfalls. There will be some rough times, but there will be some good times as well. And the overall goal is to actually improve comfort. For us, it's about quality of life. If we can make the dogs more comfortable, then the dogs will enjoy their life better, and the owners will feel like they've got their companions back. But equally, if you can make them more comfortable, you can increase exercise tolerance. If you can increase exercise tolerance, you've got more chance of shifting that weight. If you can get them moving around and losing that weight, maybe you can start decreasing your reliance on some of the anti-inflammatories. We do explain to people that whatever our therapies, there's no silver bullet here. But what we hope is that actually we can maybe reduce our reliance on some anti-inflammatories or some adjunctive therapies. But it is a journey, and it remains a journey. It's all about quality.
Yeah, definitely. Okay, so I am not ignoring people's questions. I've seen your question, Verity. I'm not going to ignore it. Oh, put that away, Hannah, put it away. What we're going to do is we're going to talk about a case coming into the clinic and what sort of things that you would do, so that people can see what is now happening at these dedicated clinics, which you're one of the first in the UK. And this is why the topic is the future of OA management, in that this is becoming such a big deal. It's one of the biggest welfare crises for dogs, for companion animals, So you are, over the next decade, going to see people focusing more and more, because it's the biggest threat that we have to our companions' animals' lifespan, health span. So at your dedicated clinic, what would be the journey of arrival? So a new person arrives. I'm going to give you a 2-year-old golden retriever who's wiggling from their waist quite a lot, has just been diagnosed with bilateral hip osteoarthritis secondary to hip dysplasia. And the owner is really keen to get life and health span. And they're happy to come back to see you on a regular basis. They've got great insurance. What would be a journey that you could envisage with them? Just kind of play it out for us.
Okay. I think the first thing for us is relaxation. It's got to be relaxed. If you've got a stressed dog, then the gait analysis is just not going to work. If you imagine somebody that's going out for a nice jog and they're running around the park, you can look at them and you can see how they're moving, and you can sort of read them. if they're being pulled every which way and they're being chased by a mugger and there's cars coming flying every which way at them, that's not going to be reflective of that jogger's gait. So similarly for us, everything is just very, very calm, very, very hands off.
So you don't have many people in your clinic at any one point. So this is pretty dedicated.
No, it's absolutely, it's literally from the second they walk in, everything is just hands off. If we have reactive dogs, if we have very anxious dogs, our consults are an hour. First consult is always an hour. And very oftentimes, if that dog is reactive, and quite often some of our cases have been showing either fear or pain-related aggression, the first 15 minutes we'll totally ignore the dog. We'll throw a few treats around the room, but we won't even look at the dog. It's just in my side sight, I'm just kind of watching how it's moving and see how it sits up. If they can jump up at the surface, this is a big thing in the military dogs, to see how well they can hold a tame and achieve a hop position. So I might put some treats up on the countertop and just see if the dog can actually get up there. And if it can hold itself up there, I'll watch them how they're sitting and how they're moving. But that's the first bit. The second bit
is... Pause, let me just interrupt. Yeah. So you've got this beautiful clinic, nice entrance, just getting people to visualize this, nice waiting room. There's no hustle and bustle. There's not people collecting prescription meds. There's not a cat in a basket winding the dog up. There's not a budgeriguard behind you. There's one vet working. So it's uber chilled.
Yeah.
Okay. We've now come into the consult room. It's huge. So there's not this kind of little cardboard box type thing that most of us work in with a table in the middle. And then you've got time, which is everybody's enemy at work, is time. So you've got an hour and you can spend the first 15 minutes just talking about the owner's observations and history and just doing like a bit of, detective work as the dog's walking around. So then what happens?
It kind of depends on the dog. So if I've got a dog that comes in it's come to me with radiographs, it's had CT scans, it's had post-surgical CT scans, it's got wealth of information, why do I need to feel it? I don't necessarily. If the CT scan is describing a medial buttress or it's describing an effusion, then all I'm going to do by trying to repeat that is upset the dog. So what we'll actually do is very often we don't do the clinical examination. If I'm going to do a clinical examination in terms of manipulation, and I do like to sort of feel things myself, but I'll leave it right to the end. I don't want to upset the dog at all. So we'll focus on a little bit of familiarization on the treadmill. So quite often there's just some real positive reinforcement, a few treats, a little bit of sort of dry run-throughs with the treadmill not working. And it's just getting the dog used to it. Now, we've done hundreds of runs now, and I can only think of 2 flat-out refusals that we've had. One of which was a big roughy-toughy army dog. He was the size of a barn door, not having it. Quite happily take down an armed intruder, but going on a treadmill, no, not happening. So with some just very gentle, lots of encouragement, bags of enthusiasm, we'll get the dogs on there. We've rarely failed, and it's just about, that's the key bit. If I can get that baseline of the gait, that gives me something to work on. So
do you use stance as well, or just gait?
Say again?
Do you use stance analysis as well?
I do use stance as well, because it's very interesting. Sometimes what the dogs are doing passively does not match what they're doing dynamically, and especially where you've got bilateral disease, or even more complicated disease. Say you've got bilateral elbows and lumbosacral disease, or you've got something else going on. So the times we've got one joint is actually quite rare. So we'll do the stance to see how they're passively standing, and then marry that up to the dynamic measurements as well. So
can I just butt in and say something? Really, for me, it's kind of humorous. Most textbooks that we refer to still talk about unilimb, uni joint lameness, and we're like, I never see that. It's always comorbidity. There's like
Not in this place.
not ever. And then for people that just want to know what we mean by stance and dynamic. So stance is the same as a normal weighing scales that you'd see in a vet. And it's divided into 4 quadrants where you can have the dog standing as square and as natural as possible, and you can get an idea of the percentage weight carriage for each limb. So you can hopefully use that as maybe towards a diagnostic tool. It supports what you might palpate or visualize, but also it's there to be used as an objective monitoring. So hopefully if you're reducing the pain in a limb, they will happily start to weight bear on it again. So it's another way to objectively monitor, because that's something that really lacks in the way that we treat OA across the board is, do we really check whether what we're doing is working? And something to be really proud of in the people that are really obsessed with it, like me and Drew, is that we're always trying to go, what I've done and clinically reasoned to do, has it worked or not? You know, it's not a case of blanket treat them, see them later, and, you know, hope for the best. It's so these tools, partly diagnostic, but collecting baseline data from which to refer back to. Continue, sorry.
So just to give I don't know if this will show on screen, we'll see. But this is the kind of data that we can get. So what we're looking at there.
Nice.
There you go. You can see a pressure and force distribution. So the dog in this case is looking into the screen. Those are the front legs in front at 105 and 104, and then 62 and 60 for the hind legs. You can see also those little peaks.
Yeah.
So anything over about 15 kilos, we can get enough differentiation on the treadmill to pick up the amount of pressure going through individual toes. So it's really, really sensitive. We can then go up, and you'll see, I was going to make myself.
That's nice.
Go there. And you can see really clearly about where the foot surface area, you can see the pressure going through the toes. You can see the pressure going through the hind legs, through the hind feet. So it's those sorts of parameters. And then one of the outputs from the machine is things like stride length, steps per minute, and it also calculates a symmetry index. So it's looking about how symmetrically the dog is using its limbs in relation to each other. So it will compare left fore to right fore and left hind to right hind. And anything over 5% is considered lame. That is to say, it is asymmetrical. Now, we can't link any of these findings to pain. There are mechanical reasons why a dog can be offloading or be unbalanced. So you have to be really, really sort of clear about that. This is not a pain monitoring system. This is a gait monitoring system. But we can infer, according to our clinical examination, what is then happening. So, for instance, this is where it's important. So we talk about monitoring of data. So if you imagine if I was walking on a treadmill and I'm going at 5 kilometers an hour and I've got really, really sore hips, then I'm going to be adopting pretty much a shuffling gait, short steps. And in order to keep up with the treadmill, I'm going to be walking sort of quite like this.
Yeah.
Now, assuming that something happens to my hips to make them more comfortable, my stride length will increase. But if I'm running at the same speed on the treadmill, then my steps per minute will decrease accordingly. Yeah. Also, the way that my legs are being used, that symmetry index will also come down. So we could have, say, a symmetry index of 20%. And what we're aiming for is to reduce that, say, sub 10%. And at the same time, see increased stride length, decreased cadence. Because there's no reference range for any of this. An 8-year-old male German Shepherd weighing 40 kilos shouldn't have a step length of X centimeters. Every dog's gait is unique to itself. And this is why it's important that we're effectively measuring the dog against itself. Yeah. So we get a baseline, then we'll say do a therapy, or we'll introduce a lifestyle change, or we'll introduce weight loss. And then we follow them at periods afterwards. And the standard that we tend to do is 1, 3, 6, and 12 months, because then that kind of mirrors the longitudinal studies that have been done in dogs for some subjective things like client-based questionnaires. They're very, very useful, but they're still subjective. They're based on opinion, whereas this is objective. This is the dog's gait at 5 kilometers an hour for 30 seconds is this, and we can compare it to the next time. So that's the way that we do the baseline. I'll always run the dogs outside as well, and it's something that is rarely done in practice. And there's two reasons for that. One is pure time pressure. My wife works in small animal practice, and she is absolutely at the sharp end. And it's just the pressure to get the number of clients per day to see is just relentless. And so stopping a consult when you've only got maybe 15 minutes to go outside, run up and down the car park, assuming that there's not cars coming every which way, it's just not feasible. The other thing is that a lot of vets are just not tuned in into looking at lameness. So there was a very elegant study where they actually took some hind limb lamenesses in dogs and got 3 different vets to look at them. And not only did they disagree on the severity of the lameness, they also disagreed on which leg was lame, because it's not something we routinely look for. And it's absolutely totally accepted that when you have a lame horse, you trot it up and down. And vets and vet students are very attuned early on to looking for those lamenesses. We don't do that in companion animals.
No. And also we've got, it's not just back and forth, there's turning circles and there's, walking, trotting, and it takes a huge amount of time.
Yeah. And I come from a lucky background in this respect. In the military, we did inspections for everything, because our job was to keep the dogs healthy and in work, not wait for them to go off the road. So we would do pre-course inspections, mid-course inspections, post-course inspections, pre-posting inspections.
But this is what's really interesting is that it goes back to that very, very first conversation about how we need to change people's mindsets.
Absolutely.
That this is health promoting. We vaccinate, we flea treat, we worm, we have annual assessments. This is the biggest killer of dogs. Mm-hmm. Done. We know this.
The interesting thing about
so little.
Yeah, those figures that you quoted earlier on from Duncan's study are the most striking thing about that was 2 things. Firstly, is the change in the incidence rates. We have always worked from thinking that 20% of dogs will be affected by OA during their life, but that clearly is a woeful underestimate.
Yeah. Even in my obsession, I've been obsessed for 8 years now, and it went from 20%, which was done by the telephone poll in 1996 with Johnson and all. Then it went up to 30, then 35, 37. Now it's hitting 40, and you're just like, it's going up, and it will keep going up as we become more and more apt at picking up on the subtle signs of pain. Definitely, this year is the year of behaviour.
So I think that's the one thing, is that big jump in numbers. The second thing is that young cohort. Was it 12 months to
8 months to 4 years?
8 months to 4 years. That's a frighteningly young population to be having OA. And this is where, I think one of the big misunderstandings broadly, right across the board, is just what OA means. Because arthritis, pure and simple, is just an inflamed joint. You do not need to have bony change to have arthritis. All you need to have is pain and inflammation within the joint. For whatever reason, it is pain and inflammation within the joint. If we grade arthritis from 1, which is the earliest onset with pain, lack of mobility, swelling, effusion, to 5, where you've got end-stage horrible cauliflower hips that you see on the advertising material, you've got bone-on-bone end-stage disease, you can get up as far as grade 3 without any radiographic change. So that's another striking thing from our study, is that the clinical signs of osteoarthritis can be happening way, way earlier than when you see it on the X-ray.
Yeah.
And just because there are no changes on the X-ray does not mean you can exclude osteoarthritis as one of the differential diagnoses.
Yeah. But also, the study also shows that you can have radiographic OA, but without clinical signs of pain, which is another thing, in that we're all taught not to treat just the X-ray. You know, the X-ray is there to substantiate your findings, make sure it's not a tumor, make sure it's not some other complication, comorbidity. But yeah, the figures are daunting. I just went at COVID brain, fog, and just thinking, you know, it's quite a strange situation we're in, because my clients that have younger dogs are more proactive. They will do more, comparative to my clients that have a 12, 13, 14-year-old dog. They'll be more palliative care. So this is going to go off, as far as I can see, once this data gets out there and people really do realize that that intermittent lameness that they see 3 times in a summer, that they think is because they ran for the ball, and, you know, in a 3-year-old cockapoo or whatever, they're going to be like, well, what else can I do? So let's now jump to the future of what things are developing. Both of us will put our things up. We have nothing to gain from this. We have no vested interest. I am not working for any company that we might mention. There's no exchange of finances. We're just going to talk what tools we now have in our toolbox. So let's actually, I tell you what, we can try and tie it in with this question. Yeah, it kind of flows with what Verity, 2-year-old spaniel, OA in both elbows, quite badly, already on meloxicam and Librela. 2 clinicians have said stem cell therapy wouldn't change much. Advice, please. So you've got a 2-year-old. It sounds like it's got end-stage OA, so it's got significant osteoarthritic changes radiographically. Play with it. Verity, this is a case study. It's not real life. We're just going to play with what would happen if you came to see Drew.
Theoretically and hypothetically speaking, so when you start thinking about intra-articular therapy, you've got to take a step back and just think about what's going on and what it is you're trying to achieve. Okay, there is no cure. This has been said time out of mind. There is no cure for osteoarthritis. There's no magic bullet. There is nothing that will work. That will just stop everything and just halt the progression of the disease or even reverse it. So such a thing does not exist. So what is it we're trying to achieve in a case where we have advanced disease? Well, first of all, we need to think about what's going on inside that joint. So we know that there must have been, by definition, for there to be severe osteoarthritic change, bony change within that joint, the inflammation must have been going on for a considerable period of time prior to those radiographic changes. Those changes don't just happen overnight. They take weeks, months, years to develop. Inside that joint, then, we know that there's probably going to be degradation of the cartilage. There's going to be effusion, and by effusion, that simply means an increased volume of fluid. That is where effectively the joint is trying to protect itself. So when you think of fusion, think of the same way. If you get a graze, you get grazed skin that's inflamed, and you get that sort of serous fluid. It's not quite the same thing, but it's a similar idea, that you have this inflammation and more fluid gets packed into that joint. You have restricted motion because over time the joint becomes it becomes almost fibrous in the way that the capsule around that joint. So where it previously should have been 2 nice gliding surfaces with a fairly elastic capsule around that joint to allow normal range of motion, it becomes stiff. You get decreased, and that part of that can be the dog itself. It just don't want you to move it. So with that in mind, we've got inflammation, we've got cartilage breakdown, we've got, if you think about it's a rambling answer, sorry, but we are speaking.
No, go for it.
So the way I describe to our clients is that osteoarthritis is like a seesaw. Okay, so all of our joints, less for my knees, are in just a permanent state of healthy flux. There's this idea that joints are just stable. You grow up and that's it. That's what you're now given, and they're not. They're in permanent flux. So cells are being destroyed, cells are being created. And that could be the cells around the synovial surfaces. It could be the cartilage cells. It could be the cartilage matrix, but it's in balance. What gets destroyed gets replaced. So it's in a sort of balance. With arthritis, that balance goes off. You get inflammation, you get trauma for whatever reason. It could be because of how they've grown up with dysplasia or any one of a number of reasons. And gradually, over time, the amount that gets destroyed increases, the amount that gets remade, remodeled, repaired decreases. You get more inflammation, more destruction, less growth, less building, more inflammation, more destruction. And this is how this seesaw just gradually goes off and off and off and off and off until you get to this unstable, really, really painful joint. If you go and put stem cells into something like that, it is entirely reasonable to assume that they're going to have a really hard time. Yeah. People think of stem cells as these sort of super tough, cells that will just go in and make everything magically better, and they're not. They are in themselves quite fragile.
Vulnerable.
They're delicate little things they are. Stem cells. You've got to look after them. So, and the other thing is that it's not the stem cells that you put in that are binding and are doing, and having these effects. What they're doing is they're using their ability to signal to the body's own repair mechanisms. And I kind of, one of the analogies I use is like a building site. A joint is like a good, well-functioning building site. You've got stuff being torn down, you've got stuff being built. There's foremen or supervisors going around and making sure that everybody knows what they're doing, and the amount, and everything's in order and everything's structured. And in arthritis, the balance goes off. You get more being destroyed, but the building's not happening, and the supervisors are nowhere to be seen.
Just giving up. He's buggered off.
And so to in some ways, the stem cells are like almost the raw materials to go into that building site and say, right, I need to fix.
I'm surprised that you don't use the army analogy. I can't believe being in the
army. Terrible organisation in the army, especially with me in charge. It's terrible. So anybody that worked with me in the military, so in that basis, so we've got these cells, this population of cells, and we put them into an inflamed joint. What is it we're expecting them to do? Are we expecting them to get rid of this new bone? They won't do that. Are we expecting them to have an anti-inflammatory effect? Well, they probably will do that, but it will only have a certain effect for a certain period of time. Are we expecting them to induce the body's own stem cells to actually be attracted to start the process of repair? Well, they will do that, but it's, again, think of that chaotic building site. It's all over the place, and so they're going to have a difficult time. If you're going to use stem cells, there's an argument to say that they need a healthy population, they need a healthy scaffold, they need a healthy framework to integrate into. And so there's other ways that you can actually achieve that. And this is where you come into layered approaches for intra-articular therapy. One of the frustrations that I have almost daily is that there's no algorithm, there's no right or wrong. A 6-year-old German Shepherd with bilateral hip dysplasia, grade 4, should get this, and the 2-year-old Labrador with elbow dysplasia should get this. That doesn't exist. We have to use what science we have to try and deduce what is the best thing to do. And by putting stem cells into a really, really severely inflamed joint, it will have an effect. It will have an anti-inflammatory effect. It will not fix that joint. But this is where over a period of time, you could actually modify what you do at different times. There are some products that you can put into a joint that will have an anti-inflammatory effect and they almost form a 3D scaffold. They bind into damaged cartilage, they bind into that joint over a period of weeks. That provides you your anti-inflammatory effect. That provides you a more comfortable joint. That's when you bring in your raw materials at a later date to then come in, because the scaffolds
Which goes back to this onion skin that we were talking about, in that there's a very different attitude to OA. People want a quick fix. I don't mean to be rude, but people want you to make big leaps quickly.
Yeah.
Whereas in this case, if we could do anything we wanted, you'd tap the joint, find out what degree of inflammatory change was there, think, right, I'm going to now use artemisinin, I'm going to use PRP, I'm just going to flush the joint. I don't know what I'm going to do, but it's too inflammatory for me to put the stem cells in. So I'm going to pause, and then you're going to come back because you like me, and I'm going to see you in 2 months, and we're going to do it again, and we're going to check that moment. But that's just not happening yet, because multiple sedations, multiple costs, still lack of, significant guidance. When do we go into the world of experimenting compared to treating? There's a lot to be unpacked there, isn't there?
Just to be absolutely clear, this is a really important take home for everybody. I think it's really important to know that this approach to arthritis management, whether it's the detection, whether it's the intra-articular therapy, all of these novel approaches that we're talking about, they are not new. Mm-hmm. So all of these approaches, all of these therapies, all of these agents have been well established in equine practice for 10 plus years. It is just that the companion animal side of things, so domestic animals, whether it's dogs, whether it's cats, even rabbits. I've had people ringing us up asking about advice for rabbits. Can they be injected? A joint is a joint is a joint, but for companion animals, it is relatively in its infancy. And so what we're doing is there is plenty of peer-reviewed evidence in all of these agents to show that they work. So if you have an arthritic joint, you put things into them and then they get better. That is proven. That's not, there's no guesswork about that. There is proof. Where it then lacks, this is the brave new world, and this is the exciting step forward, is what do you do in the early cases? Mm-hmm. Having treated them, what do you do next? If you've treated that 2-year-old with stem cells and it gets better, what do you do next year? Where do we go? How do we think? And again, we have to go right back to basics and think, what is it we're trying to achieve in that joint? We're never going to make it. We're never going to make an athletic dog into a marathon runner again. That's just that's the pragmatism.
I can remember there was a study out a few years ago about arthroscopy of elbows. Mm-hmm. And we all are very much conditioned to believe arthroscopy is really good for medial coronoid disease and pulling out the fragments and stuff. And this study, I think it was looking at like 60 odd dogs, and it looked at the longevity, so it wasn't a short-term response, which they did well, but over time, those that have been treated conservatively compared to those with arthroscopy, level playing field. But that's because the study was stretched over years, and that's a different kettle of fish to a short-term 28-day study, which is still expensive and hard to do. But now try and do it over 12 years. So that 2-year-old spaniel, we had 20 of those that had stem cells repeatedly. We had 20 that only had stem cells when they were acutely lame. We had another 20 that had stem cells with PRP. That's just not going to happen, is it?
And everything from the Chihuahua to the Great Dane, and that's a whole new level of biological variability that becomes very difficult to manage.
Yeah.
So
just going back to is it Verity? I don't know. Verity. And this 2-year-old spaniel. Let's not leave her hanging. Try and just offer a little bit of advice. Verity, you're more than welcome to speak to Drew. He's at Nupsala Musculoskeletal Clinic. He will give you the time to chat through interventions that are available. There's commonly used stem cells now off the shelf, autologous stem cells that you collect from your dog, PRP, which is from your dog's own blood, polyacamide gel. They're like the big players that people are using to fit in the joints. I think I love your attitude to being more targeted. I think that's really, really good. Have you got a physiotherapist involved? Are you learning, basic therapeutic targeted exercise? Is your dog at the appropriate weight? If you stop throwing that ball, is it stop jumping out the back of the car? Is it not jumping on off the sofa being like a crazy thing? Have you got your lifestyle all sorted? There are many other things that you can bring into play. You've got physios to work with you?
Not on site. We work closely with physios, and again, another big message is osteoarthritis is a team sport. Yeah. It's definitely, everybody's got to tie in. Quite frequently, the only person that doesn't buy into the plan is the dog itself. And particularly we do a lot of work with working dogs, and the that whole idea of rest, nah, that's not happening. And that in itself is a challenge for us, because very often these dogs they're very fit, they're very active. They have things that need to be managed, but they also will not switch off. Yeah. So it's a continuing sort of challenge to try and think of ways to modify training, modify work, modify so for dogs that are essentially kennels versus dogs that are in a home environment, that's a big challenge.
Totally different.
I come from our biggest kennel section within the Army had in one block was like 204 kennels. That's a really stressful environment for a dog.
It's so stressful.
But for the 99% of those dogs, that was the environment they were brought up in, this environment they were used to.
I'm just thinking of all the dogs with elbow disease just bouncing off the door.
That's the kicker, and that's where you have to try and think about modification means.
I'd have licky mats all the way around the wall. They'd just be glued, licky mats all the way around.
Everyone loves a licky mat.
I love licky mats. There's so many of them. Okay, so hopefully, Verity, that gives you a little bit of you've got connections now, Verity. You've got people that you can talk to. Debbie, yes, it is a published study. I will try and find the link and put it up here on the thread. Blah, 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 blah. Which is this one? Didn't catch starts. Who missed the clinic? Where the clinic is? Melton Mowbray. What kind of costs are involved, please? My petite 18 kilo father, elbow display, back issues, starts nurses. Well, Stacey, get in touch with Drew. He's extremely approachable. And we did talk about prices, which we're not going to talk about live now. But even I was quite surprised that actually, considering the amount of dedicated care you get, bearing in mind that you're the only one in the clinic for any which point, very, very doable. And Luke. Oh, Luke, it's nice to see you. Didn't come to the Canbasta meeting on Monday, did you? But it's okay. I'm watching you. Right, so let's go back to the interventions that you have available. Do you do intra-articular on everything?
No. No, not necessarily. Sometimes it's a case of I've been finding a lot of cases, and you mentioned this, dogs and animals generally don't walk on their images. Mm-hmm. And one of the mantras that we use is let's chase the pain. What I described to you when we were before we started, if you've got arthritis in your knee and a drawing pin sticking through the sole of your slipper that's sticking into your heel, yes, your knee might be an issue, but it's that drawing pin that needs dealing with initially, because that's where the current pain is, and that's the current. So we quite often see concurrent issues. So I quite often see particularly heavy set working dogs that are quite sort of should we say kinetic in the way that they work. They don't kind of open doors, they just go through them. So having things like, we see elbow arthritis in those dogs, we see lumbosacral disease in those dogs, but we also quite often see things like biceps tendonitis, and supraspinatus tendonitis. And that's what's bothering the dog. The dog's been living with osteoarthritis. And I always remember, I wish I'd kept this one image. I could sound very sad there. It's a bit of sad violin music. It was Christmas Eve and I was working in the clinic. And this, it was whilst I was in service. And this big dog came in, he was called Max. And we went through a raft of Maxes. We had loads of them for some reason at one point. And Max came in with I kind of think it was a forelimb lameness. He was just a bit lame on his elbow. And because within the military, again, we're really keen on proactive, looking really early. We x-rayed Max. Normally, you wouldn't be x-raying a dog like that. But we're like, well, we can. He's starved. Let's get it done. Let's get the answer. And we x-rayed that dog, and I found absolutely nothing on his forelimbs. And I found his entire spine from mid-thorax all the way down to his sacrum looked like a cheese grater. It was the most horrific spondylosis.
Right. Oh, so did he a dish? That one where it's just fused?
It was some fused, some were not. It was just the most horrific looking spine.
Oh yeah.
I guarantee that dog would chase down anybody, and he never.
I like dogs more than people.
He had just, and seeing the X-rays, I went back to see him again, and I was like, oh my goodness, and we looked at him, and we sorted out his forelimb lameness, but his back wasn't the issue. So this is a thing of we just need to be not necessarily seduced by the easy answer. It's, you see the hip X-rays and there's, oh my goodness, there's a grade 4 arthritis. Look at those nice little cauliflowers all going around there. Yeah. Well, that's our answer. But actually, concurrently, that dog's also got a grade 1 OA in its tarsus or in its stifle, and that's what's bothering it. That's the bit that's really owie at the moment, and that's the bit where you've got to listen to the owner. You've got to listen to the dog. The dog will show you.
It goes back to time, though, doesn't it? This is the big thing. I think that, set aside your amazing tools, that you've got the brilliant gait analysis, dedicated nurses, you've got your intra-articular, approaches. Big player is time. Massive player. And I was reading an article only yesterday from the human sector about OA management. And the most, game-changing intervention is giving a person with pain time. That is going to change the way they feel about themselves, the way that they manage their pain, whether they hit their targets, they actually follow your treatment plan, they trust you, time.
Isn't it interesting how for almost all human conditions, whether it's arthritis, diabetes, whatever, there is a support group.
Yes.
Where like-minded individuals can share notes, share time, share stories, share ideas, and work together and that it's almost like we need a OA groups for dogs where these similarly affected dogs can come together and actually go, well, have you tried this? Have you thought about that? That really worked for me, or that didn't.
And do you know what? I've actually I need some people to start sponsoring me. I've got a syllabus I created for a 6-week group course, so that people with dogs with similar conditions could come together on a weekly basis. There'd be one vet, one nurse, and they'd take a group, so maybe 10 owners, and you would be sharing your stories, you'd be cross-comparing notes, you'd be looking at each other's dogs, but you'd also emotionally be able to exchange the woes, the highs, the lows, everything. I so want to bloody do it. I just haven't got a sponsor. So anybody that's listening, I want to sponsor. And I want to sponsor for FAM as well. I need £25,000, please, so we can do feline arthritis management.
Absolutely. I mean, for me, from our approach, I do have in fact, on our Facebook site, you probably have got to scroll down a while now, but we do have a cat on the treadmill.
Yeah.
Very, very beautiful and talented Duke, who's a Maine Coon, bigger than some of the dogs we've had on the treadmill, actually.
Really?
And he just came in for a baseline, so and just to see what it was like to have a cat on the treadmill. I'm not naive enough to think that all cats will go on the treadmill.
I'll bring Flea and Worm up. We'll see how they do.
So if we do this again and I've got scratches right across my face, then I'll have given this up as a bad idea. But cats are equally affected and equally important. They're not the poor second cousins of the veterinary profession.
No, definitely not.
They have a voice as well.
They're harder to work with, I won't lie, but they really do need attention. And
I'll do my best. Military cats never really took off as a concept.
Did they not take off? Oh, damn.
Cats, not a thing. But but I've had cats with OA, and actually, and I didn't know about this stuff then, and I absolutely would have tried it in one in particular who was just she had terrible elbows, and it stopped her doing things. And other than pain relief, what could I do? And I think it's one of my frustrations is right across the board is the normalization of osteoarthritis.
I know.
It is expected. It is, they're just stiffening up a bit.
Yeah.
Oh, he's not limping, he's just a bit stiff.
Yeah, no, absolutely. I agree.
So,
and did you ever hear about when I got myself into near trouble? Well, I always get myself into trouble. Alabama rot. I think there's been like 220 cases over about 5 years or whatever. And it's got a huge sensational headline. People living in the town were washing their dog's feet. There's no chance they're going to get Alabama rot because it hit the media. Everybody knew about it. So we did a post and we were like, we're going to change the name of arthritis now, joint rot. It was like, yay! Because actually, as you said, arthritis has got this apathy about it. And there's tens of thousands of dogs being diagnosed every day with OA or not diagnosed. It just seems kind of daft that there's such a lack. Let's do there's a couple of questions. I'm beginning to fail. I won't lie. I'm beginning to get the fog. I'm losing my concentration. Let's go down. Yes, we've done Stacey, so we're going to move down to Gemma. 9-year-old Labradoodle, elbow dysplasia, who just had a soft tissue sarcoma removed. Hopefully that was successful. Found also a protruding disc. He swims twice a week. He's currently on Galliprant long term. I give him many supplements. Anything I find hard is having that plan. Yes, you need to do one of the CAM courses, my love. Do CAM Essentials or CAM Comprehensive, and it will teach you how to start formulating your own plan. Your vet is very much there to help you, but as we said, time constraints and workload means that we can't handhold as much as we'd like. So we have created these courses for you guys to go and be equipped to make your own plans. So please do look into that. If you join the CAM member zone, you automatically get signed up for CAM Essentials. I'll just do a blatant plug. CAM member zone has loads and loads of resources that are no longer freely available on the website. And one of the best resources is you get to have a tea and chat with me and a guest once a month in a private Facebook group. So you get to pose us your questions. It's a small little affair. You get discounts, tools, resources, blogs, you name it. So join the member zone and you'll get a lot more support there. Oh, Deb, you got a new fan, Drew. Well done.
Loving the accoutrement on the dogs there. High fashion there.
Yes, absolutely. My 8-year-old Labrador is recently diagnosed with bilateral elbow dysplasia. Elbows. But I assume it must be there. He's not obviously lame, but very occasionally a subtle head knot. Vets want to do arthroscopy, but my physio says CT scan is their recommended next help. We have followed lifestyle changes for some time. Oh, tricky one. What would you do?
They're all right. This is the problem. Yeah. All of those recommendations are right. But again, this is where I think we need to start thinking outside the box a little bit and think about also. So arthroscopy is in and of itself quite invasive, quite intrusive. It's not a completely benign procedure in itself. Now, it depends what you're trying to find, and certainly costs also are a significant factor here. If you're going to do arthroscopy with advanced imaging, whether it's CT or whatever, it comes at a cost. And that cost takes you to the point of diagnosis. And the diagnosis then will allow you to formulate a plan, which you might actually have got to through another means anyway. So what we tend to do, our approach is we don't ever rule out, and I've referred plenty of dogs, especially working dogs actually, for advanced imaging. Now, the standard approach, what people will recognize is, and Hannah will probably start nodding now, is dog goes lame, dog has some anti-inflammatories and some rest. Dog goes sound, dog goes lame again. Right, well, dog comes in and has radiographs. Radiographs are inconclusive, dog goes for CT scan, plus or minus arthroscopy. And it's this sort of step up, and it's a step up in intrusiveness, and it's a step up in cost. And each level you're finding new things, or each level has its own sort of reasons. It has their own strengths and their own weaknesses. So plain radiography is brilliant if you're expecting to find something really quite overt. So if you're expecting to see a grade 4 hip dysplasia, you will see it on X-ray, and it will give you, but it's a 2-dimensional image, and a lot of, particularly elbows, are a very complex joint. You've got 3 bones trying to meet and all link and talk to each other at the same time in a coordinated manner. An elbow dysplasia means that something is off, and it's that being off that then provides the abnormal loading. It's the abnormal loading that causes the inflammation. The thing you've got to ask yourself is, having done that CT or having done that arthroscopy, what are you going to do? Now, if you do, there's some places they'll want to do a CT scan, but also have a Mark 1 eyeball inside the joint by doing the arthroscopy. And this is where I've got to be really careful, because I can't say, without sort of looking at all the circumstances around each CT and or arthroscopy is not absolutely the correct thing to do. What it might lead you to, though, is a comfortable, confident stance to say, I can leave this alone, or I can treat this conservatively. And this is the balance. This is the difficult bit that we have to face at the moment. You could, if your dog has got overt arthritis, and we've known about it, and the lameness has gone on, there is very little point in taking samples out of the joints and doing a compare and contrast. That's a very low-tech, low-cost way of determining whether you've got an inflamed joint versus another. I just did one last Friday, a very, very low grumbling, relatively early onset lameness, where I'm not thinking there's going to be anything massive on X-ray or on CT. So I just look at the joint fluid, and it tells you an awful lot. To pop a needle into each joint and look at the 2 fluids, send them away for analysis. And if you've got one with degradation products and one without, then you can treat conservatively. The difficulty is that if you treat conservatively, then the traditionalists will then say, but you're effectively treating blind, because you don't know what's going on in that joint, and you need the arthroscopy and you need the CT to have that confident, cozy feeling that you're doing the right thing. The counter argument is that the conservative treatment will not preclude you from going down those more invasive options at a later date.
At a later date, yeah.
So using something like PRP or using something like stem cells.
It's that layer of onion thing again, isn't it? Of saying to somebody, well, we can do this first and then we can do that. And some owners will like that because you've got a plan. You can see in the future there's a plan that's going to be followed. But other owners still want you to try and do a one hooly, everything sorted type situation. I'd definitely be more on the line with you, where I'd be like, okay, this is a step-by-step approach. I'm going to try conservative first, because I know I've always got that as a backup plan.
I think for me, the underpinning thing is that it underpins all the medical professions, whether you're a vet or a dentist or a doctor. It's well, its full name is prima non nocere, first do no harm.
Yeah.
And that's the key thing is, for me, is if I do something, it must lead to an option to do something else.
Yeah.
If I do something that is harmful and precludes me from doing something else, then I've done it in the wrong order.
Yeah.
So
No.
for me, doing some very minor investigations or doing a trial therapy. So I use, in some cases, I have used platelet-rich plasma diagnostically. And I'll sometimes use epidural injections of steroid. It's the only time I use steroids really for lameness assessments. But I use them diagnostically because if I get that response and if I get a positive response, then I get that warm, cozy feeling that my problem is within that joint. I'm not going to do it any harm, but I might just do it some good.
Yeah.
If the lameness doesn't resolve, or if I treat and the lameness comes back, okay, what have I lost by the sake of 4 to 6 weeks to see if something has worked?
Yeah, no, I think that's fair. This is a good question. Is there an age where you consider to medicate conservatively? That is very individual, in my opinion. It's individual to the dog, it's individual to you, and also individual to the relationship that you have with your vet. I have some owners that their dogs are 12, 13 years old and they really want to do everything, and the dog will take it in a stride. And then I have other people that have got young dogs and they really don't like the idea of doing anything interventional and it's conservative, and no one can judge you on that, as long as you are dealing with your pet's welfare, which is pain reduction to the best of your ability. We can't fault you on your choice, can we?
Absolutely. I think if you think about anything, if there was a right answer, we'd all be doing the same thing.
It'd be really boring then, wouldn't it?
It would be. I mean, it'd be an easier day in the office, but it would be boring.
It would be boring.
The key is, I mean, for me, I need to make sure. So, for instance, we treated a 12-and-a-half-year-old spaniel just recently. The images are on our Facebook site, and they're pretty badly affected elbows. And the dog has had a very, very good response.
Yeah.
What's the big inhibition for me? It was the anesthetic. It wasn't the age, or wasn't the whether or not I should treat those things. It's the secondary impacts. And this is where you need to have that holistic plan.
Yeah.
That dog had pre-anesthetic bloods, and then I worked with the vets who referred him to me, and we came up with an anesthetic plan that we were both happy with, and a post-procedure plan that we were both happy with.
Yeah.
And that's the way. So it's not as simple as you get to 8 years and you can't do this anymore.
No, 100% no. I hate that. Yeah. I used to, when I lectured, have BCCBs, batshit crazy cemented behavior moments, where basically we have some really weird things that we do. And one of the ones was when your dog suddenly becomes the old Ford Cortina that you don't want to invest in it anymore. There's this cut off where they go, oh, he's old now. No, it's fine. We're not going to put any more into him. I'm like, what? He served you all of his life. As far as I'm concerned, it's your decision. Work with your vet. And if you don't feel that you're getting the conversation that you need, ask to speak to another vet in the practice. Discussion, definitely. I was going to do 10 top tips. Do you feel like doing 10 top tips?
10?
Well, one each. Well, it's 5, and they're short, okay. Like one sentence. Yeah? It's okay. Right. And then I'm going to go and lay down. Okay, so guys, the 10 top tips are to try and bring everybody back into the room about the fact that there are a huge amount of interventions that do not cost the earth. They're available to everybody. They're here to help you, guide you in your journey. One of the things that CAM really supports is that there's 101 ways to best manage OA. You do not need to spend a fortune, be insured to the ends of the earth. So I'm going to start with number 10. I'm going to steal the biggie, weight loss. It's an utter no-brainer, guys. I know Anthony's going.
Okay, that was my one.
I know, I've got it
first.
So yeah, get your dog's body to an optimal body condition score of between 4 and 5. Number 9.
Just on that one, very well established studies that just 6% weight loss, just 6% of body weight can have a significant improvement on comfort in arthritic dogs. 6% is not a lot. So set yourself easy targets. Number 9, let's think. Exercise. Look at what you're doing. Look at how your dog might love still chasing balls, might love duck diving or fly ball or doing all the things but should they really be doing it? Or is there another way of doing it so they can get the same enjoyment but without the impact?
Love it. Number 8 on the similar vein is look at your dog's activities of daily living, ADLs, and just think what ones of them you could modify that could have a big impact. Say jumping out the back of the car, running down the stairs at high speed, being in the kitchen on the slippery floor, jumping up and down at the worktop, waiting for dinner time. There's these things that your dog will do that they're in an aroused state. So they're going to do it because they're aroused. They're not feeling pain because they're aroused. But if you actually were to reduce that, it might have a bit of a knock-on effect on aggravating those problematic joints. So watch them for a day and think, well, actually, he's not going to miss it if I just do that. So he's not going to mind that I put a baby gate up. He's not going to mind if I put a rug where I'm going to feed them. Really simple changes. Number 7.
I've got to think now. Right. Listen to your dog.
Yeah.
Just as simple as that. If your dog has always done something and has stopped doing it, if your dog has never done something and has started doing it, is there a reason? It could be the most subtle thing in the world. It could be you suddenly notice that your dog that used to run as straight as an arrow now runs sort of, where's the camera, like that, and runs in that direction. So they're running with a leading shoulder. They might always have walked past normally and suddenly they started pacing. They might always paced and suddenly have stopped pacing.
Yeah.
They might suddenly now be groaning when they lay down, whereas they didn't before. Those things are all tells, and that's your dog maybe not saying something to you directly, but saying something out loud, and you just need to listen.
Yeah, totally. Number 6, use your vet nurses. I've got to do a big shout out. The nurses that I'm working with are absolutely frigging lovely. And my dear friend Evie, she blows me away. You know, she is so super efficient, so coordinated, so brilliant in her people skills, conversing with clients, getting the best out of them. White coat effect is out the window. Please ask whether your vet clinics offer nurse clinics, because you will get a lot out of them. They're generally longer, they're generally cheaper, and they generally listen more than vets do because we're gobby. Number 5.
I resent that. Number 5, just had it on the tip of my tongue. Don't feel guilty. Don't feel guilty. It's arthritis is something that happens. Strangely, I think anecdotally, I think arthritis, the way that arthritis is happening within the veterinary profession or within the animal population is changing. That is not something you have done. The fact that you used to throw balls or do agility when the dog was 1 and now it's got arthritis when it's 8 is not your fault. You have enjoyed that time with your dog and have fun. Owning a dog should not become a chore. Yeah. So don't feel guilty just because your dog has developed away.
Yeah. Number 4, I'm going to be controversial. Don't spend all your bloody money on sodding supplements. There is so much more out there. Drives me mental when people have told me that they're doing like £100 a month on supplements, and I'm sitting there going, don't know that company, don't know that brand, never heard of that, don't know if that's the right amount, don't know if that's got any kind of clinical efficacy whatsoever. Take the time, go and see a professional, get a full examination done, get a plan, use evidence-based medicine, and try and not blow all your money on your iPad on Amazon at 11 o'clock on a Friday night. Number 3.
Does that mean I've got number 1?
Oh. You're going to have number 1 as well. Number 3.
Does that mean I've got number 1? Oh. You're going to have number 1. Oh. You're going to have number 1. Oh. Does that mean I've got number 1? Oh. You're going to have number 1. 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 Oh. You're going Let me have a think. Don't take no for an answer.
Good one.
Just because if something doesn't feel right to you, you have every right to question it. So if you are feeling like you're being led down a path which doesn't feel comfortable, just stop and ask. But please don't be rude about it. And this is a plea from the heart on this one. The veterinary profession is under extraordinary pressure at the moment. I don't want to be morbid, but national suicide rates in vets is 4 times the national average.
Yeah.
Both Hannah and I know I have lost friends. Vets are humans, vet nurses are humans. They go home, they have lives just the same as everyone every day. They have really strong feelings and they do what they do because they love doing it. So by all means, challenge and don't take no for an answer. Be willing to question why and for how long and what does it mean. And if you don't like the way it's going, challenge, but please do it kindly.
Definitely, really do. Number 2, and an absolute mainstay to the NICE guidelines for managing human OA is self-education. And, the key points in human OA management is lifestyle, exercise, education. So please dive into CAM, join the member zone, do the CAM Essentials course, do the CAM Advocate Level 1, do the CAM VP, do the courses, learn as much as you can so that you can make these educated decisions and you can create your own plan, because it is going to be permanently changing. You might have a dog that's been diagnosed at 2. You're going to permanently change for 10 years, 14 years. You don't know. So get as much information now. Number 1.
Don't wait.
Good one. You're doing well today, considering I gave you no briefing.
No briefings at all. I'm here under duress. I'm going to blink my eyes, say, please release me. Right. Arthritis, we've talked about it tonight. Arthritis happens at any age. It can happen from really, really young. If it feels off, if it doesn't feel right, even if you're having a question about it, just get it checked out. The ones I can take grade 4, grade 5 arthritis cases and make them more comfortable. That to me but it presents little challenge because that joint's got so little left to give.
Yeah.
If we can start picking up those early grade arthritis cases, and I'm very lucky in the technology I've had that I know that I can detect subclinical offloading. Myself and Ariane, my amazing nurse, we're becoming so attuned to what the equipment can do that we know, and we have proven that we can detect subclinical lameness offloading. Yeah. If we can start detecting those, if we can start getting those joints tapped before there are any radiographic changes, if we can start developing therapies for those cases, we have the ability to start turning arthritis around. And instead of being on the back foot, we're actually taking the battle to arthritis, and that's the future.
I agree. Wouldn't it be incredible that if every health check your dog has a little bit on a gait analysis and stance analysis, that you have half an hour for your annual check? You're given a questionnaire before you arrive. The Duncan Lascelles questionnaire of only 9 points, just 9 questions, picking out something like 50% more cases than would have otherwise been detected. Time would be incredible. Wow. Thank you, Drew. This is the first time that we've actually done anything like this together. I think it works quite well. I'll get you back if you're willing to come.
Let's see. Depends on whether you're willing to pay my fee.
Oh, self-important now. I'll give you wine. Wine will arrive.
I work for whiskey.
Okay, no, that's fine. I can work for whiskey too. Please say thank you to Drew for giving up his time. We're really, really grateful that all of the guests that come on and do these lives are doing it out of the kindness of their own heart. So please take the time to say thank you. Thank you for the best wishes. Yes, I want COVID to bugger off. I really do. I will see you guys next week. Please join the member zone. Please support CAM. We're here for you, but you've got to help us stay here. Until next week, see you later, guys.